Hello, this is the Bennett Minute on diabetic foot exams. I'm Janet Bennett and I'm a family nurse practitioner, and today I'll be giving a demonstration on the diabetic foot exam. I'm also going to give some information that will help reinforce the importance of this vital aspect of the diabetic primary care exam. By the year 2025, the global prevalence of diabetes is expected to reach 324 million, with approximately 54 million individuals in the United States being pre-diabetic. 60 to 70% of diabetic individuals go on to develop diabetic neuropathy. Approximately a quarter of those individuals develop foot ulcers. A half of those individuals one half of those ulcers become infected, and 20% of those require some form of amputation. So you can see why diabetic foot exams are so important. All diabetics should receive an annual comprehensive diabetic foot exam. The purpose of the diabetic foot exam is to be able to place your patient into a risk category in terms of their propensity to develop diabetic foot ulcers. And we'll discuss how to place your patient in a risk category after I demonstrate the foot exam. The foot exam encompasses a vascular, neurological, musculoskeletal, and dermatological exam. So now we'll move on to the diabetic foot exam. I'm going to move closer to my patient. Okay, in preparing for the exam, I have the patient take off both shoes, both socks, and for this demonstration I'm just going to examine one foot for the sake of time. Also have chucks on the floor for the patient in case they have to put their feet on the floor, and I also put chucks on my lap. I usually don't wear gloves. I'll leave that to your discretion. It helps to be able to feel the temperature of the foot. There have been a few instances that I felt gloves were indicated. Again, you're the one with the patient. You need to use your own judgment. I scoot up close to the exam table and I have the patient put their foot on my lap. If you'll scoot forward, please. And the first part of your examination, of course, is inspection. And you're looking for anything you see. You're looking for integrity of the skin, color of the skin, any erythema, blisters, evidence of infection, redness, indication of pressure from the shoes. You need to be sure and look for any crevices in the sole or heel of the foot. Be sure to look between the toes for any debris or evidence of tinea. Look at the nails for any dystrophic changes or fungal infection. You're also looking for any deformities that you might see. It's good to note hair growth. Hair growth is evidence of good circulation. and I think I mentioned any notation that you see that there might be any infection is important to pick up on. So after inspection, you move on to palpation, and you're feeling for the temperature of the foot. Some feet feel cool, but you want to make sure you're not feeling a cold foot. Cold would make you be concerned about circulation. And with circulation, you think about checking for the pulse. And what I usually first check for with the pulse is the dorsalis pedis. You can usually find that with your fingers horizontal, and I can feel a good pulse here. And it's good to grade the pulse. 2+ is a good, healthy, full pulse like you'd expect to find in a young person. You can find that in an elderly person as well. 0 is the absence of pulse, and then 1+ is in between. Then you also look for the posterior tibialis, which is behind the ankle. Sometimes that's a little more difficult, and I don't spend a long time looking for that if I don't feel it, as long as I felt a strong dorsalis pedis. And then with palpation, again, you're looking for any bony abnormalities or tenderness. And then the next thing you move to is the sensory exam. And you need to be sure and explain to the patient what you're doing. And the first thing I'm going to do is see if you can feel this. Sometimes it takes maybe a couple of times. And you can feel that, right? And let's see if you can feel it up here. Okay, good. And then I want you to look at this. It looks like a pin or a needle, but it's very soft. See how it bends? And I'm going to touch you with it so you'll know it doesn't hurt. See? Okay. Now I want you to close your eyes and see if you can tell me which toe I'm touching. Okay. He's indicating 3 and 5. 1, 2, and 4. Okay, you've got it. And now I'm going to check at the MTP area. Okay. 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 And then I'm going to check the heel. Okay. Oh, I told you. I shouldn't have told him where I was checking. You don't do that. So, some patients are not going to be able to feel the monofilament at the heel, and you look to see if they have a lot of callus or keratinized tissue, and that can prevent them from feeling the monofilament, and that's not a sensory defect. So, if you don't feel the pulse, you're concerned they have peripheral arterial disease. If they're not sensing the monofilament, that is loss of peripheral sensory perception. Now the next thing we move on to is checking reflexes. And since we don't have an exam table, I'm going to have my patient kneel on the couch, so I have his Achilles exposed so I can check his reflex. Now I'm going to flex his foot just a little bit, and hit the Achilles, and you can see just a little bit of the reflex there. I'll do it one more time. Try to relax. So we'll discuss the categorization of the risk. If the patient has no loss of sensory perception and no coronary artery disease, no musculoskeletal defects, he's at 0 risk, and he just needs to have a comprehensive exam annually. Now, for my patients, I still do a periodic visual exam. A patient is risk category 1 if they have mild loss of peripheral sensation and maybe a mild deformity, then they need a comprehensive exam every 3 to 6 months. And also both categories need good education and And risk category 2 is peripheral artery disease and plus or minus loss of peripheral sensory, and they need to be referred to a podiatrist, and usually the podiatrist sees them every 2 to 3 months. And then every diabetic that's had a previous foot ulcer or amputation needs referred to a podiatrist, and the podiatrist determines how often they need to be seen. So, I hope this helps your primary care practice, and this has been a Bennett Minute from Janet Bennett. Thank you.